All righty. Can everybody see my screen?
Yes.
Awesome. Hi, good afternoon, everyone. I'm Dr. Gozan. I'm one of the internal medicine residents at UPMC Lititz. I was asked by Dr. Dang to give a presentation today, and we chose an interesting topic of asthma. I know I wanted to first start off really quick by thanking you all for everything you do for us. Pre-hospital care is very important. I work more on the inpatient side and closely with Dr. Deng in the ER. But for me, we always had a saying when it came to EMS services. For us in the hospital, we are medicine of the hour one all the way to the end of discharge. You guys are medicine from the first 5 seconds from the initial encounter. And I'm so appreciative because often when we get our patients from you guys, we have all the information that we need. And for you guys, oh my gosh, I can't even imagine. You really have no information. You have to use a lot of your clinical exam skills and assessing the information. A lot of my friends who are in emergency services, whether they're EMT, EMS, etc., they often tell me all of the horror stories. And I'm like, man, I take for granted a lot of the information that I get prior to the patients coming to the emergency room and eventually to our unit. So again, I'm very appreciative for everything that you guys do and a lot of the things that you guys go through. So let's begin. So let's start with a small introduction of asthma. Asthma is a chronic disease, which we characterize as airway narrowing, or what we call bronchoconstriction. We have mucus plugging and inflammation that's involved. As you can see here in the picture to our right, you can see a kind of cartoon of showing what the bronchioles and kind of what the airways look like. Somebody who has asthma, essentially, if we think about a pipe, the pipe is essentially a lot thinner. Therefore, air isn't able to go in and out as it usually does. In situations where they have a lot of mucus, so as you see here, this also blocks air from coming in and out. And then we also have inflammation, which can also make these passageways a lot smaller. It affects about 24.7 million people in the United States, and it causes about 3.5 thousand deaths per year. This was a statistic that was actually drawn in the last couple of years. It is actually the most common chronic childhood disease, and it's a frequent call for EMS. I know that when I was asking my friend about this, he lives all the way in Evansville. I go, hey man, when somebody says, oh, shortness of breath, they're like, oh, it's probably asthma. And I go, oh, why do you think that? They're like, oh, we get this call all the time. Oh, really? So one of the big things that we always note is that asthma continues to be one of the leading causes of respiratory compromise. Now, even in the light of COVID, in the light of all of these new respiratory viruses that we're dealing with, asthma in itself continues to champion as one of the most common causes for respiratory compromise nowadays. Prompt recognition of asthma can quickly relieve symptoms and improve patient outcomes. And this is going to be the core of our discussion today. Now, one of the most important things that we always talk about is information that we get. Often that we have to get information either from the patient or a family member who is called EMS. For us, I'm lucky because usually you guys come with that information, or if they're stable enough, they'll tell us, but there are often times when they can't tell us and we need to recognize these symptoms. So I wanted to delve a little bit into what we call the pathophysiology of asthma. So asthma in itself, we always think about what triggers it first. Triggers are what we're going to gather from our history. And essentially what the triggers do is they cause this exaggerated immune response. What this leads to is that sudden bronchoconstriction, inflammation, and mucus secretions that we saw in the last slide. This typically happens in the upper airways. And so when we think about triggers, and these are questions we ask the patient or the family member who's speaking on behalf of the patient, they'll include allergens, viral illnesses, exercise can do this, and stress as well. This is important because when we think about asthma and some of the causes and types of asthma, things like exercise and stress-induced asthma become very important later in the discussion after we stabilize the patient and in terms of what treatment we're going to give. So when we think of asthma, when we think of someone who does not have asthma, typically when we breathe in and out, our respiratory muscles normally relax during exhalation. When somebody is having an asthma attack, they often need more muscles to push air in and out of those constricted bronchioles. And so typically they'll start using their abdominal accessory muscles. And what this would usually cause is what we call a prolonged expiratory phase. as we were talking about earlier, for us to push more air in and out of our of the airways during an asthma attack, we actually get this turbulent flow. We always describe this as wheezing. It sounds kind of like that sound. What's interesting is when you try to describe wheezing to an individual, they typically know. I always found it, I always struggled with it when I wanted to describe this in a second language, when I'm like, okay, so somebody's asking, well, what is actually wheezing? And again, when we're trying to push air with these constricted airways, it's that idea that you're pushing turbulent air through a very, very tight tube, hence the asthma attack. And so that's what you're hearing when you hear wheezing on exam, whether that's through auscultation with a stethoscope, or sometimes you can actually hear it if it's very severe without a stethoscope at all. Now, one of the most important things that we need to pay attention to is if they have signs of what we call severe asthma attacks. And the reason why is because asthmatics who cannot fully exhale before their next breath, this causes what we call carbon dioxide trapping in the alveoli. Essentially, they're not able to excrete all of that carbon dioxide. And if you think about it, if they keep continually building more and more carbon dioxide, their body is going to want to get rid of it faster. So what is the body's response to doing that? They breathe faster, they breathe harder. And there becomes a point where they can't actually get rid of this carbon dioxide. So if the work of breathing increases and increases and increases, and they can't get that carbon dioxide up, they eventually tire it out and they lose the ability to compensate. Typically at this stage, this is when we have to call for intubation, for additional ventilation, because they can't breathe on their own. And again, they essentially go into respiratory failure, which is what we're trying to avoid when we treat these patients. When we think about patients with asthma, then, since we know that this is becoming an issue with carbon dioxide trapping, asthma in itself, and this is the mentality that is hard for me when I first learned about asthma to understand. It really isn't about oxygenation in this point, but more in ventilation. And when we describe ventilation, what we're talking about is gas exchange. And so it's the idea of when we breathe in, we're getting in oxygen and then breathing out that carbon dioxide. Patients who have asthma, let alone severe asthma, have impaired ventilation, aka they cannot exchange gases like the normal individual does. One thing I'm going to focus on our presentation is one of the most vital tools, which is capnography. It is a vital tool that we use here at Lititz, whether you're in the ER, in the ORs, and our ICUs. And essentially what we're looking at is the end-tidal CO2. And so one thing that we want to note is that somebody who has asthma, when you hook them up and you look at their end-tidal CO2, they get this shark fin pattern. Essentially what this is showing us is an uneven expiration pattern. And as you look at it, when you look at the peak and how sharp these shark fins are, the more carbon dioxide they're trapping, you'll actually see a more pronounced end-tidal CO2. And so if they have more carbon dioxide trapping, again, increased rate, so it's thinner, we're starting to notice that these are signs of severe asthma attacks. And again, things that we need to pay attention to, whether we're on the field or in the ER, because it precludes to worse outcomes if not treated adequately. And we'll talk more about that in future slides. So I made this a little bit more on the interactive side. I wanted you guys to tell me, what are some signs and symptoms of an asthma exacerbation? I know what I see when I see here in the ER, but usually when you guys see them, again, it's medicine of the first, couple seconds. What are some signs and symptoms? If you guys would like to unmute yourselves or type it in the chat, please let me know.
Wheezing.
Wheezing, yep. What else?
Chest pain, accessory muscle use.
Yes, chest pain,
Contractions.
accessory muscle. Yes, I like this. Anything else? All righty, these are all really good answers. So the first ones I want to start off were the mild and moderate symptoms. We talked about the wheezing. Sometimes they'll say, oh man, I have this really bad cough, not realizing that, hey, I might be having an asthma attack. I could have chest tightness. I get that as a description. Typically when I see them in my clinic, I also work clinic outside of the hospital, say, oh, my chest feels really tight. I can't breathe. Of course, that's a common one. And shortness of breath. These are signs of mild and moderate. One of the things, one of the audience members said this, and it's really important, which is use of accessory muscles. Once you start seeing that they're starting to use their abdominal muscles, more importantly, if they're unable to speak in full sentences, if they're agitated, confused, drowsy, or if you look at their vitals and they're very tachypnic at greater than 30 respirations a minute, or their heart rate is greater than 120, these are signs of severe asthma and things that we need to pay attention closer to. Why? Because again, it portends to us having worse outcomes at the end of the day. And again, for us, whether you're on the field or if you're, in the ER, this again will help us determine what are we going to treat them with, how are we going to treat them with, and more importantly, like what is their outcome going to be at the end. So let's talk about some diagnosis of asthma. Now, this goes a little bit more into, outpatient care and how we determine what asthma is and how do we make that diagnosis. Usually when I get them in my clinic, I work a little bit of primary care. I always ask like, oh, how do you know you have asthma? And they're like, oh, well, my doctor told me I have asthma. They gave me some albuterol and my shortness of breath got better. That's sort of a halfway true statement. Typically nowadays, because of COVID and the shortage of albuterol that we're having right now, we become a lot more restricted in just giving out albuterol, especially in treatments for asthma, whether it's diagnosed or not. And so when we think about somebody who has asthma, the first thing we want to do is always look at a good history and physical exam. Again, we talked about the symptoms, the cough, the wheezing, the chest tightness, the shortness of breath. We ask about things like triggers like dust, fume, and allergens. But the most important thing that we do in an outpatient setting when determining if someone actually truly has a diagnosis of asthma is something called spirometry. What we're essentially measuring is the fractional of expired FEV1 and their FVC, which allows us to calculate this ratio, what we call the FEV1 and the forced vital capacity or FVC ratio. And if it's less than 70, this shows that they have a obstructive pattern. When we think of obstructive patterns, we think of either asthma or COPD. Now, I know like for us, we're like, oh, really, what's the difference? And it really does come down into what medications we're going to treat them with, which we'll talk about a little bit later on. When we want to confirm if they truly have asthma, what we look for is if we do this test, we tell them essentially to blow into a tube and we measure essentially how much volume that they're able to, breathe out. And then of course, when they inhale, we measure that. We look and see if we basically measure it against standards that we have across several individuals who fit the same race, age, sex, all of the above. Then we basically compare them. And so what we're looking for in somebody in asthma is if we give them a bronchodilator, aka albuterol, and we see that there is a change, that their breathing gets better. And so it's somebody who is asthma, typically it's what we call reversible. They should have at least that 10%. And if they're not symptomatic, usually their PFTs or their pulmonary function tests will be completely normal. Now, this is the gold standard. This is how we know if somebody truly has a diagnosis of asthma versus, well, their doc just gave them some albuterol and they got better. Again, getting better with albuterol is part of the criteria. However, if we truly want to make the diagnosis, we actually go through this testing. We do also have additional testing, which is the exhaled nitric oxide test. Usually we use this if we're not really certain about the PFTs or if the patient has persistent allergic asthma. Again, there are different types of asthma, and the one that we'll typically see again is your bread and butter, just regular asthma from an allergen, more than the exercise-induced. Typically, patients will know, and you can get that by history. I showed some pictures of some PFTs of some patients that we've had. And so the one above basically shows a normal one, which shows that, hey, here's the volume when we expire and then how we inspire. When you compare that to someone who has a significant obstruction, you can see that our essentially the fraction that's when we're having exhalation is reduced. And you actually get this kind of like doming effect over here, this concave appearance. And so that's how we know. And then again, when we get the data, it gives us all of this information. Now, Joe Camel is not a real patient, but this is kind of like what you would expect to see from our perspective. So one thing that we talked about again is obstructive patterns, asthma versus COPD. Now, typically, when we see this already in the ER, we'll kind of know a little bit based on history, looking at their medications, and even just looking at some ages. But say you don't have any of that information. Again, when you guys first see these patients, they may not even know they have asthma or COPD because they've never been diagnosed. Or my favorite, they're fugitives of medicine. They don't like seeing doctors or seeing me, or they can't recall. So when we look at asthma versus COPD, they're very, very similar in the sense that when we look at the PFTs or the pulmonary function tests that I showed you earlier, they look a little bit similar, but their presentations are quite different. So when we think of asthma, we think of usually younger patients. Usually they're younger than 45 years old. If they're more of a COPD patient, these are our patients who fit under that greater than 45. They've been smoking for a long time. I've seen patients who have used to work in factories, or when I was out in Lehigh Valley, it was very common because we had a lot of our co-workers who also developed COPD on top of some of their other chronic issues. The symptoms are very similar. In asthma, again, you have that cough. We talked about the wheezing, we talked about the dyspnea, the chest tightness. But what's important is that the patients who have asthma, truly, they'll have a period when they're not having exacerbations. They're asymptomatic. They feel like you and I who don't have asthma. Individuals who have COPD on the other chance, they'll have the cough, the dyspnea, but then they'll also have symptoms of right-sided heart failure. Essentially, when they're trying to, if they're trying to walk, they get shorter breath. When they'll have persistent wheezing. If you listen to their lungs, whether you treat them or not, you could still hear some of the wheezing. Typically with asthma, it gets a lot better, or if not resolves with treatment. When we think about exam findings, we talked about what we said earlier. They'll be tachypnic. These individuals with asthma, they'll be wheezing. We talked about some of the severe symptoms where if they're using abdominal accessory muscles, if they're tiring out, they'll become fatigued. I've had somebody fall asleep during a conversation because they were just so fatigued. That patient ended up getting intubated, things of that sort. COPD on the other hand, you'll have decreased breath sounds. You'll notice their barrel chesting. It's very impressive on a chest X-ray. When we take that, you'll essentially see two, very large lung volumes. And then again, you can see pursed lip breathing as well. When we talked about that confirmatory testing, the pulmonary function test, or PFTs, they both share that obstructive pattern. Again, when we calculate the FEV1 and the forced vital capacity ratio, essentially what we're looking at again is for this obstructive pattern, if it's less than 70% of what we consider the standard normal. And when we look at somebody who has asthma, again, if they have that 10% improvement while they take albuterol right before that test, that's usually a sign of asthma. In COPD, you'll see some improvement, but even after, if they're not having exacerbations, they'll still show that obstructive pattern. And now the more important thing, and we'll talk about this because I had to kind of do a little bit of research as to what medications we have in the hospital versus what you guys have in the trucks or available to you on the field, is how we treat them. When we think about treatment for asthma, we basically use a severity scale on the outpatient side. We think about it as this intermittent, and then we define it basically on how many symptoms and how often they're using their albuterol. So is it mild, moderate, or severe? COPD, on the other hand, we use a GOLD criteria. So we classify them through A, B, C, and D. And this kind of determines what medications would be optimal for them. Since this is really a focus on asthma, I didn't want to focus so much on the COPD. But when we talk about treatments, it becomes important to distinguish asthma versus COPD. So let's just talk a little bit about what I do in some of the long-term treatments. I discussed this earlier in terms of asthma. We use we determine by severity. If somebody, we're getting the history and they're able to talk to you and they say, hey, I just have asthma and I just use one inhaler, and they pull out the albuterol, typically this is a sign that, oh, this is probably just kind of a mild or if not intermittent asthma that they get. Again, we look at symptoms, how often they get them when they're just on albuterol or on no treatment. But if they continue to get worse, we start adding other medications. So once you start seeing things like, oh, they have albuterol plus they have corticosteroids as well, or if they're on some stranger medications, I know we have omalzucumab, prednisone, if they're also on a long-acting beta agonist, and they'll be able to kind of show you the medications. You'll notice that they have multiple inhalers, strange names. This is how you know that it's a little bit more severe. With COPD, again, it's based on their symptoms and their risks. So again, group A through D, sometimes we can get away with just doing a long-acting, like a long-acting anticholinergic plus a long-acting beta agonist. So this would be like salmeterol plus tiotropium, and then you can also add Combivent as they needed. And as they get worse, we start adding other medications for Flumarax. Sometimes we'll have them on azithromycin if we think that they are, prone to having infections, things like this. But again, the reason why I bring this up is because if they're able to show you their medications or somebody mentions it, more medications essentially means that they're sicker. And that, again, we pay attention a little bit closer to those. So let's talk a little bit about the pre-hospital evaluation. And this is where you guys step in and where it gets really tough because you're working with a lot of limited information. You don't have everything that we have in the ER in hospitals. So often when you guys are called, and I ask my friends this, I go, hey, when somebody calls you about shortness of breath or asthma, like what usually is going on through their mind? Usually they're saying that the patients are usually saying like, oh my gosh, my asthma feels, quote, worse than it is than normal. They're non-compliant. And by non-compliant, I don't mean that, oh, they're just not taking their medications. Sometimes it means that they forgot their medications on vacation or, with the albuterol shortage, they couldn't get it filled on time and they're having an attack and they can't get themselves to a hospital. So they call 911. Those are, what we talk about in terms of non-compliance. And of course, if they continue to have symptoms after their treatment, which kind of ties into, oh, normally I'll use my albuterol inhaler. I've used it 7 times today. I'm not getting better. I think I need to be seen by someone. So again, taking that good history of triggers such as were they ill? Did they have COVID? Did they have flu? Was somebody sick around them is important. Allergens, etc. This is all important to the history. And of course, as somebody mentioned earlier, you'll hear wheezing, whether if you guys auscultate or they'll say, hey, I think I'm wheezing, and you can actually audibly hear it without a stethoscope. Now, a lot of this is happening simultaneously. I'm not really a, checklist. This happens, then this happens, then this happens. In the back of our mind, whether you are on the field or if you're in our ER, you always assess the ABCs. It's almost like second nature. My friend who is in EMS says, yeah, we're always thinking about this. And I'm like, I'm glad because, this is one of the most important things that we think about, especially when they hit the door in the ER, which is, do they have signs of the severe asthma? Do they have decreased level of consciousness? Are they using the respiratory muscles? And are they able to speak to us in full sentences? If they're not having all these signs, we get a little bit more worried and we treat them a lot more aggressively. This also speaks to us whether we should be worried about impending airway compromise, again, respiratory failure. Capnography, again, is one of the cornerstone tools that we use in the ER, and I know that you guys also use on the field. And why it's important for us is because it displays that real-time feedback on the respiratory rate and the amount of CO2 eliminated at the end of exhalation. When I was first learning about asthma, when I was a young med student, I was like, oh man, it's all about like not getting oxygen. And when in fact, it's not really an oxygen issue. It's more of an exchange issue with carbon dioxide. And so I always go back to the capnography because it is so important. And it's one of the most fundamental tools that we can get on the field. I can't draw like an ABG right away sometimes. This is a lot easier and gives me a lot of information. As you could see here below, I actually put a normal capnography. You notice that you have these nice plateaus. You see that the end tidal CO2 is around 30 to 40, which is about normal, versus above where you see that loss of plateau. You see that they're actually, above that normal of 40, we're approaching the 60s. And again, as the sharper these get and the thinner they get, the more frequent that they're breathing. And again, the more CO2 that they're retaining, signs of respiratory compromise and signs that they may end up going to respiratory failure. I wanted to go a little bit more in depth to the pulse oximeter part, because again, this is kind of a common mistake when I teach some of our interns or med students about asthma, which is, again, it's useful to detect hypoxia, but that is usually a late finding when we think about asthma. Pulse ox doesn't tell us anything about ventilation. And I always reinstate that because my med students always tell me like, oh yeah, what does the pulse ox tell me? And I say, hey, that really doesn't matter in this rate. I'm not going to look at the if they're hypoxic to determine whether or not our treatments are working. We look at the whole clinical picture, and especially we look at the end tidal CO2. So again, when we think if they are actually having hypoxia with their asthma attack, this tells us a couple things. It tells us that one, they're extremely tired, they're already fatiguing, and that they're unable to inhale effectively. And again, this is more in severe cases. The other thing that it also tells us is that, if it's normal, that doesn't, they could still be having that mild to moderate asthma. That basically tells us that, hey, they're not hypoxic, maybe it's not as severe, but I'd never rely on that for any of my asthmatic patients. Recall that asthma in itself, again, is more an issue with ventilation, again, gas exchange, than it is with oxygen, getting oxygen into, our, getting oxygen to our tissues. So we should talk about some of our treatment goals. And I wanted to look at kind of some of these treatments, and please correct me if there are things on here that are not in the truck or included. but what we have to understand more. So what do our meds actually do? I know that you guys are equipped with medications. And so one of the things that is the most common thing is albuterol. Albuterol in itself, the way that it works is it's a beta agonist. What it does is that it binds to the beta receptor of our lungs. So long story short, what that does is when we turn on these beta receptor in the lungs, it allows for the bronchial smooth muscles, those constricted airways to open up. We call that bronchodilation. And so essentially when you open up those vessels, you're allowing for gas exchange to occur because you're actually having a much more open, airway to allow them to, again, exchange gas. This is important because when you ask about like, oh, is your breathing getting better? What is our alveolar actually doing? We're opening up those airways. Hence, when you think about the wheezing that you're hearing, it could get better. Why? Because we're not hearing that turbulent flow that goes through those constricted vessels in someone who has asthma. Typically, this is connected to supplemental oxygen between 6 to 8 liters per minute. And if they're very severe, you could use CPAP. What it does is that, again, it will push air and essentially force air into the lower airways and improve gas exchange. Now, of course, if we don't know if it's severe or not, we're question. Some people will actually start them on CPAP. Once they hit the hospital, we're welcome to, discontinue and get them on lower oxygen. But you don't want to underestimate someone who's in severe asthma. Again, that's why we look for those heralding signs and we look at the end tidal CO2. The next thing that we're going to talk about is atrovent or ipratropium bromide. So ipratropium bromide, we saw that you can use it really in COPD management, but it can also be used in asthma as well. And essentially what it does is it inhibits the mucus secretions by inhibiting the vagal response. Part of when we talk about the mechanism of asthma is that you have increased mucus secretions. And so by you giving them ipratropium, what you're essentially doing is you're stopping those mucus secretions from happening. Now, I know when I was talking about COPD treatments, we talked about, you typically will add something like atrovent. And the reason being is because when we think about the severity of COPD, we look at how much mucus they're producing. That isn't necessarily the case in somebody who has asthma. Now, this is really important. And typically, again, these are usually in combination with each other, but ipratropium in itself is not a replacement for albuterol. I often I tell my med students that they're like, oh, you can use one or the other. The answer is no, you have to always have albuterol. Why? Because even if you get rid of the mucus, you stop it from secreting getting worse. If the site is still very constricted, you're not going to help gas exchange by any means, and they could, again, get worse. So it's important that albuterol, again, it's the first line treatment and it's the cornerstone treatment for asthma in these scenarios. So we also have corticosteroids. Now, whether that's methylprednisolone, so Solumedrol, or prednisone, which is the oral form. This decreases inflammation related to asthma. Now, I know that I believe that your trucks are equipped with it. And so the most important thing about it is the onset of this medication. The point of corticosteroids is to help, again, decrease inflammation, hopefully, open the airways up. When you have a lot of inflammation, you have a lot of swelling, those airways get really tight. Corticosteroids can take up to 4 to 6 hours to work. Now, the question is like, well, why would I give that on the field? Well, having that started earlier, they can have relief a lot sooner. So while they're in the ER, they can actually start to feel the effects of the corticosteroids, once they're with us a little bit more stable. Part of what we do, and I'll discuss this later, is we observe our patients. If we're able to get that medication to them sooner, this is really helpful to them. The last thing is, and this is more of an adjunctive medication, is magnesium. Magnesium in itself is a great adjunctive medication. What it does, again, it just relaxes those bronchial muscles. What's really nice is we've also used it for muscle aches. If they're having, muscle spasms, muscle pain as a result from increased breathing, a lot of it comes with panic and anxiety. Magnesium is actually really good in terms of calming, getting that calming effect, but also relaxing the muscles. And again, it's used in addition to the nebulized bronchodilators. Albuterol, as you guys all know, is the cornerstone and should always be used in these asthmatics. It's a very safe medication. The other medications that we have listed here, again, are adjunctive or they work a lot later in the process. And I just wanted to know from your perspective, because again, I don't really work on the field or in the trucks, were there any other medications or are all of these medications available to you guys readily?
Yes, we have access to all these medications at Warwick and no other ones that I know of.
Awesome. I know sometimes they've mentioned that, what's the role of epinephrine? Because I've seen that as, somebody has asked me that question. Epinephrine in itself is really useful for if you're thinking of anaphylactic shock, if you're thinking of severe allergic reactions. Typically by history, we'll get that information. If you think, if they look like they're having severe asthma and you're not really sure, in such a scenario, you could also use epinephrine. However, again, epinephrine in itself will not change the outcourse of what's going on with the asthma. But if you're thinking of something else that's going on, again, keeping that wide differential, that is something that can also be useful. So let's talk a little bit about the hospital evaluation. So again, you guys have done your evaluation, you've started them on treatments. And once they hit our doors, we essentially reevaluate the exacerbation. So timing is really important. When did they get steroids? Did they respond to the albuterol? Did they respond to any of your treatments? And so what we always do is we always think about our ABCs. We look at the airway, we look at their breathing, we look at their circulation. And the most important thing is we're looking for those signs of respiratory failure and respiratory distress, unless you guys have already told us about it. So we're, again, adding on to what you guys have started. What we do is we start to titrate their oxygen to greater than 92%, whether we put them on high flow, nasal cannula, supplemental oxygen. We give them some duo-neb treatments. So again, that's albuterol plus the Atrovent. And then we'll also give them Solumedrol as well, again, to add on top of the Solumedrol you already given, unless we don't deem it as that severe. But for us, we're pretty liberal with giving that. At this point, this is where we have more time to look at, since you guys have already started the initial treatments, it buys us time to look for alternative diagnoses. So, we'll shoot a chest x-ray, we'll do a CBC, CMP, we'll look at their blood work essentially. We can look for COVID, we can do an ABG if we want to. But essentially, again, we're looking for other reasons for them to have asthma. Even though you guys have probably treated it, made some of the diagnosis already, we've already seen, hey, is there something else, or is there something that would have caused that, which is more of our job. Again, if they have pneumonia, we would start them on antibiotics. If it's heart failure, we can diurese them with diuretics, things of that sort. And so if they show clinical response, so say they have their asthma exacerbation, you gave them treatments, they get to our doorstep and they're feeling much better, wheezing is resolved. We typically watch them for a little bit, make sure that they're doing well. And then we reassess. We look, are they hypoxic? Are they, what's their end tidal doing right now? Do they look better? Do they feel better? Do they have a safe discharge plan? That's what we really do in the ER. And again, as if they end up getting admitted, questions that I start to ask, like who's following up with them? A lot of the scenarios, that is not the case, that they don't go home. We have a lot of scenarios where their symptoms persist. If not, they could even get worse. And a lot of these patients end up in our ICU. Why? Because if we're worried about their asthma getting worse and we need to have an airway, we'd rather have close eyes on them. So we'll have them admitted to the ICU. At this point, based on the information that you guys have already provided the ER and what the ER has already done, they've already paged me upstairs in the hospitalist suite saying, hey, I've got this guy, he's a 32-year-old male. His asthma was treated with several rounds of DUNEBs. He's not getting any better. I think we should take him in. And I'll already start my workup on there. What we do is if we end up admitting them to the hospital, we continue the albuterol treatments. We give them additional steroids. With the continuous albuterol treatment, we'll just let it run for about an hour. We'll give them some magnesium if you guys already haven't given it. Again, more steroids. And typically we'll consult pulmonary critical care to see them. When we have somebody go into what we call status asthmaticus, essentially they've failed to respond to a lot of our treatments. Their asthma is getting worse. They're building more and more CO2. This is when the call for intubation is needed. And a lot of what's been going on in the first, couple hours will help us determine if a patient's going to end up needing to be intubated or not. And so again, that's why they end up in our ICUs. So I wanted to keep it kind of brief. And I know we talked a lot about asthma, a little bit about the pathophys. We talked a little bit about, treatments, what we give in the hospital, what we give outside of the hospital. But ultimately, I wanted to kind of keep it short and sweet. Asthma in itself is very important, and it is something that we see a lot. But before I kind of go into the rapid slide, I have a little bit of a quiz for everybody just to see if you were, paying attention. And so it's pretty easy. So feel free to unmute yourself once I have the option choices up. So let's start with the first question, which is, which of the following symptoms are associated with severe asthma? Is it A, shortness of breath, B, cough, C, chestitis, or D, inability to speak in full sentences?
D.
Okay, so I heard one for B. Anything else? Again, for severe asthma. In the chat,
D is in dog.
D is in dog. D is in dog. Okay, D. Good, good, good. I like it. I like it.
C, and D.
And so we have a lot for D as in dog, and the answer is D as in dog. So as we said earlier, shortness of breath, cough, chest tightness, these are all signs of asthma. You can see them in severe asthma, but we start to get worried if they can't speak in full sentences. Accessory muscle use, if you hook them up to the monitor and you see that, oh gosh, they're very tachycardic and you notice they're breathing like 40 times a minute. And I actually mean looking and seeing that they're they're breathing that fast. We start to get worried about severe asthma. And again, the treatments we give, yes, maybe it might help the symptoms, but if we start thinking, do we need to tube this patient in the hospital? Are they going to need to be admitted? Or, if they get better, hey, could we send them home? And again, a lot of the cases, they don't go home as a result. All righty, so I talked a lot about end-tidal CO2. I talked a lot about capnography, but which of the following capnography waveforms is consistent with asthma?
A.
We got A. Anybody, any other answers?
A.
A. A. A lot of A's. All righty. And the answer is A. So actually, as you look at your waveform capnographies, again, it's a vital tool that we use both in the ER, but you guys also use in the field, and it's readily accessible. Individuals who have bronchospasms, asthma, you're going to see the shark fin pattern. If you see that, it is, much more pronounced. What I mean by that is the end, when you think about the peak, it's much higher. If it's greater than 40, if you're reaching 60s, 70s, you start to get worried. Especially if they have carbon dioxide trapping. That CO2 trapping, again, the body's response to it is, I'm going to breathe faster, I'm going to breathe harder. And if they're not able to get rid of that CO2, they tire out and eventually they go into respiratory failure. B is actually just a normal, capnography. If I were just to hook it up on any of us, unless you guys have some underlying lung conditions. C is just hyperventilation and D is just hypoventilation. So that being said, asthma attacks are one of the most common EMS responses and things that you guys deal with on the field that's respiratory involved. Timely pre-hospital care is actually proven to improve patient outcomes. So essentially recognizing asthma, getting the history, knowing your treatments and what they actually do and how it benefits the patient is extremely important. With that all being said, here's a lot of my references that I used for this presentation. And I just want to thank everybody for their time. I wanted to leave a little bit of time for questions. And also with everything going on, I wanted to, give you guys a little bit of a break too. So that's the end of my presentation. Does anybody have any questions or anything to discuss?
Dosage of methylprednisolone pre-hospital, what would you consider appropriate for a maximum?
Oh, sorry, I didn't get the question. What was it?
For pre-hospital methylprednisolone,
Mm-hmm.
what would your thoughts be on a maximum appropriate dose?
So you said if you've given the maximum appropriate dose, like what do I think about that essentially?
What would you give for a maximum dose?
Oh, for a maximum. Okay. Yeah, typically, 40 is a good place to start. If you've given 40 at that point and they're really, we're not going to see the results of it until much later. I would say that would be a safe bet. Once you start approaching, much higher doses, we'll start to see side effects to it. So 20 to 40 is typically the range, at least when I kind of looked into it. And what I typically see is safe. We usually work with that. In the hospital, we can always go up on the amount of methylprednisolone, but if they end up having like side effects to it, again, increased agitation, things like that. If they're having, let's just say they have fluid retention, things like that, or if they have really terrible diabetes, once you start increasing the methylprednisolone beyond that, we'll start to see significant side effects and worse outcomes as a result. Yeah, that was a really good question. Any other questions? Also, I hope hopefully that answers your question, by the way.
Okay, Dr. Gosm, thank you so much for speaking to us today.
Yeah.
For the rest of the group, the next session starts at 1 o'clock. It'll be Airway by our own DJ Johnson. So tune in for that. You'll have to go through the links to get to that presentation.
All right. Thank you everybody for having me. And again, thank you for everything you all do. I really appreciate you guys personally. And at Lidditz, we love you guys. Thank you again for your time. And I hope you have a great rest of your day.
Thank you.